Usually, medical side effects follow a pretty predictable, like a straight line.
Right, yeah, cause and effect.
Exactly. You take a beta blocker to lower your blood pressure and your hands get cold because of the restricted blood flow. Or, I mean, you take an antihistamine for your allergies, it crosses the blood-brain barrier and bam, you're drowsy.
Very straightforward.
Right. But when you step into the world of female sexual biology and, well, complex pharmacology,
Yeah.
that straight line just completely fractures into this tangled web of neurochemistry.
Oh, absolutely.
Yeah.
It gets incredibly complicated very fast.
It really does. So today, we are looking at a physiological paradox that sits right at the center of that web. Welcome to the deep dive, by the way. I'm talking directly to you, the learner, because we know you appreciate cutting through all the information overload to find those real aha moments.
And we have a really fascinating mission for today's deep dive.
Yes, we're going to answer a very specific, very complex question based on our stack of medical texts. Does low dose on naltrexone or do neuromodulators affect vaginal transudate?
Which is just one of the most interesting intersections of neurology and vascular biology we have in modern medicine, honestly.
I mean, we're exploring whether a drug typically used at high doses for opioid addiction or an antidepressant notorious for drying out your mouth could actually restore vaginal lubrication.
Yeah, and we're pulling this from a really robust set of sources today. We've got biology overviews from Boston University, clinical guidelines on vulval conditions, and some cutting-edge case studies on pharmacological compounding for chronic pelvic pain.
It's a lot to cover, but we are keeping it structured and jargon-free.
Mm-hmm.
But to understand how a drug like naltrexone or amitriptyline affects something as specific as vaginal transudate, we kind of have to establish what that fluid actually is first.
That is step one, definitely.
Because when you look at standard diagrams or hear casual explanations of anatomy, there's this pervasive assumption that vaginal lubrication operates on the exact same mechanical principle as, like, saliva or sweat.
Right, people just assume the vaginal wall is lined with these little secretory glands that actively pump out fluid when there's a stimulus.
Exactly. But that's totally wrong, isn't it?
It is a fundamental misunderstanding of the anatomy. I mean, there are absolutely no glandular elements in the normal human vagina. None at all.
But none.
None. What we actually perceive as lubrication is a transudate.
Okay, a transudate. Break that down for us.
So a transudate is a highly specialized plasma filtrate that comes from the blood. In a baseline, unstimulated state, the vaginal epithelium, the surface tissue, sits on top of this really dense microscopic capillary bed.
Okay, so a network of tiny blood vessels.
Exactly. And that tissue is constantly reabsorbing sodium from those capillaries, which keeps a basic level of moisture just to keep the tissue healthy.
Right.
But it's not lubricated.
Right, it's just maintaining the baseline.
That's it.
During sexual arousal, the nervous system shifts gears.
Yeah, the parasympathetic nervous system takes over. The
Got it.
pelvic nerve sends a signal that dramatically changes the hemodynamics or the blood flow of that entire region.
So we're talking about a massive, localized spike in blood flow straight to that capillary bed.
A huge spike. The vascular engorgement happens so fast, and the pressure becomes so intense that it just completely overwhelms the tissue's normal ability to reabsorb that sodium.
So the fluid literally has nowhere to go but out.
Exactly. The sheer hydrostatic pressure forces an ultrafiltrate of blood plasma to seep directly through the intraepithelial spaces, basically the tiny gaps between the actual cells.
Oh, wow. So it's squeezing between the cells.
Right. It starts as this microscopic mist on the vaginal wall, and then it coalesces into a continuous lubricative film. A healthy vascular response will push about 3 to 5 milliliters of this fluid through the tissue.
I always think of this like a standard soaker hose in a garden. You know, those ones made of porous, recycled rubber.
Yeah, that's a perfect analogy.
Like if you barely crack the spigot, the water pressure is low, so the hose just feels maybe slightly damp to the touch. But if you crank that spigot wide open,
The internal pressure forces the water to weep right through the porous walls and soak the soil.
exactly. And in the human body, the neurochemicals acting as the hand on that spigot are primarily nitric oxide and VIP, right? Vasoactive intestinal polypeptide.
Yes, nitric oxide and VIP. They bind to the smooth muscles wrapping around those capillary beds, and they basically force them to relax. That is what allows that massive rush of blood to fill the vessels.
So it's all about smooth muscle relaxation.
Entirely. Nitric oxide is the primary driver there. It kicks off this whole cascade involving cyclic GMP that keeps the vessels dilated. As long as the parasympathetic nerve is firing and NO is being released, the pressure stays high and the transudate just keeps filtering through.
Okay, so if this entire mechanism relies on relaxed, smooth muscles and uninhibited blood flow, we run into a pretty massive roadblock when we introduce chronic pain, right?
Oh, a massive roadblock.
Because you look at conditions like vulvodynia, which is this idiopathic chronic vulvar pain, or vestibulodynia, where there is severe localized pain right at the vaginal entrance. Those conditions essentially hijack the nervous system.
They do, and the clinical texts we pulled from, particularly Graziotson's anatomical overview, they highlight this non-negotiable rule of physiology.
And what's that rule?
Pain is the absolute strongest reflex inhibitor of vaginal lubrication, period.
The strongest inhibitor.
Yeah.
Mm.
When a patient has allodynia, which is where a normally harmless touch, like, the friction of clothing or a doctor using a cotton swab, registers as this agonizing, burning pain, the sympathetic nervous system just flares up.
Because it's a survival mechanism. The body perceives a threat, hits the panic button, and floods the system with adrenaline and noradrenaline.
Exactly. And the sympathetic nervous system clashes directly with the parasympathetic arousal response. And, well, survival always wins.
Fight or flight takes over.
Right. The noradrenaline causes extreme vasoconstriction. It aggressively clamps down on the smooth muscles around those pelvic capillary beds.
So it's basically redirecting the blood flow away from the reproductive organs because you need to fight or run away.
Exactly. The nitric oxide signaling gets completely suppressed, the capillary pressure drops, and the transudate process just instantly halts.
The spigot is violently shut off.
Violently shut off, yeah.
Which brings us to the first part of our mission today. If pain is the ultimate off switch for the transudate response, how do neuromodulators fit in? Are these advanced medications actively stimulating the lubrication to overcome the pain, or are they just trying to silence the alarm bells so the body can do its own thing?
They are entirely focused on silencing the alarms. Neuromodulators don't have the chemical ability to act as synthetic secretagogues.
Meaning they can't tell the body to just make fluid.
Right. They can't make fluid. Their whole job is to alter how the nerves transmit pain signals.
So, like amitriptyline, the tricyclic antidepressant.
Yeah, that's used as a first-line defense for unprovoked vulvodynia, usually starting around 10 milligrams and titrating up. Or you have gabapentin, an anticonvulsant, which modifies nerve pain and can be used in doses up to 3,600 milligrams a day.
Wow, 3,600. So by heavily modifying that neuropathic signaling, they lower the intensity of the pain and remove that reflex inhibitor.
Exactly. They allow the sympathetic nervous system to finally stand down, and theoretically, that unkinks the hose so the nitric oxide and VIP can get back to work.
Okay, but theoretically makes sense until you look at the actual side effects of a drug like amitriptyline.
Ah, right, the anticholinergic effect.
Yeah, I mean, anyone who has taken a tricyclic antidepressant knows how bad the dry mouth gets. The drug blocks acetylcholine receptors systemically. It causes severe dry mouth, dry eyes, constipation.
And dries everything out.
So wait, if amitriptyline literally dries out your mouth as a side effect, wouldn't it severely dehydrate the vaginal transudate too? It seems completely counterintuitive.
It does seem counterintuitive, and that paradox trips up a lot of clinicians, honestly. But it comes down to the specific neurotransmitter pathways for different tissues.
Okay, how so?
Well, salivary glands rely heavily on acetylcholine to trigger saliva production. So when amitriptyline blocks acetylcholine, your saliva production stops. But the vaginal capillary beds, they aren't primarily driven by acetylcholine.
Oh, right, we talked about this. It's the nitric oxide and VIP.
Exactly. And we have robust data on this. The Boston University texts detail Giuliano's rat models, which isolate this exact mechanism.
They used atropine in those models, didn't they, to chemically block the acetylcholine?
They did. Atropine is a very potent anticholinergic. So they administered it, chemically blocked the acetylcholine, and then stimulated the pelvic nerve.
What happened?
They found that blocking acetylcholine did not significantly reduce the vaginal blood flow or the transudate.
Wait, really? It just kept flowing?
It just kept flowing. The vascular engorgement relied almost entirely on the nitric oxide and VIP pathways, which the atropine didn't touch.
That is wild. Meaning the physical pathways for making saliva and making transudate are just totally distinct?
Totally distinct. You can chemically shut down the mouth's ability to produce fluid without shutting down the pelvic capillary bed.
But didn't they use another drug that did shut it down?
Yeah, clonidine. It's an alpha-2 adrenergic agonist, so it affects sympathetic tone. When they introduced clonidine to the models, it severely impaired the vaginal engorgement.
Okay, so the math with amitriptyline actually works out in the patient's favor.
It does. Even with the risk of some mild systemic dryness, the relief from that agonizing nerve pain provides this massive net positive. By removing the pain, you remove the primary reflex inhibitor.
You let the parasympathetic nervous system take the wheel again?
Exactly.
But there's still a huge structural flaw in using oral amitriptyline or gabapentin, right? The collateral damage.
Yeah, the systemic side effects are tough.
I mean, you might be unkinking the vascular hose in the pelvis, but to do it, you're bathing your entire central nervous system in this heavy drug. Patients get intense fatigue, brain fog.
And that severe dry mouth, yeah.
So you, the learner, are probably wondering the same thing I am. Is there a way to target the pain and inflammation right at the source without sedating the whole brain?
And that leads us to the second half of our focus today, low-dose naltrexone, or LDN.
Okay, so standard naltrexone, prescribed at like 50 milligrams, is a powerful opioid antagonist. It blocks opioid receptors for 24 hours to treat addiction.
Right. But when you reduce that dose down to a micro level, we're talking between 1.5 and 4.5 milligrams, the drug's profile completely flips.
So at a microdose, it's only blocking the opioid receptors temporarily, like for a few hours.
Exactly. And when the body's feedback loop senses that its receptors are blocked, it assumes there's a deficit of natural painkillers, so it overcompensates.
It kicks into overdrive.
Yeah, floods the system with a massive surge of its own endorphins and enkephalins.
So it's essentially tricking the body's thermostat to pump out natural pain relief. But that's not even the most critical part for chronic pelvic pain, is it?
No, the real magic is what LDN does to something called toll-like receptor 4, or TLR4.
TLR4. Those are the sensors on microglial cells, right? In the central nervous system.
Yes. And microglial cells are basically the frontline immune defenders for your brain and spinal cord. In chronic pain states, whether from trauma, infection, or just prolonged stress, these microglial cells become highly reactive.
They get stuck in the on position.
Right. They overexpress TLR4, and when those receptors are activated, the microglial cells dump pro-inflammatory cytokines into the surrounding tissue.
Oh, so it creates this localized storm of neuroinflammation.
A massive storm. It hypersensitizes the nerve endings, which is what drives that burning allodynia we see in vestibulodynia.
It's like the smoke detector is going off constantly. The microglial cells are the detectors screaming that there's a 5-alarm fire in the pelvic nerves, which triggers all those sympathetic panic responses.
That's a great way to put it.
So what does LDN do to the smoke detector?
LDN acts as an antagonist on TLR4. It binds to the receptor and essentially takes the batteries out of the smoke detector. The microglial cells can no longer sound the alarm, the localized inflammation finally powers down, and the nerves stop misfiring.
And the real breakthrough with this, according to the case studies from compounding pharmacies, is that they are bypassing the oral route entirely, right?
Yes. Places like Town Country and Rockridge pharmacies are compounding LDN into a mucoadhesive vaginal cream or gel.
Sometimes mixed with a microdose of amitriptyline or gabapentin right in the base.
Exactly. And you apply it directly to the vaginal vault and vestibule.
So it absorbs straight into the tissue where the microglial cells are actively causing the neuroinflammation. You get that immediate, localized immune modulation.
You shut down the cytokine storm at the source, and because the dose is microscopic and applied topically, the medication barely hits the systemic bloodstream.
So you completely bypass the systemic fatigue and the brain fog?
Completely. And returning to Graziotti's rule, this localized approach perfectly removes that reflex inhibitor. The burning nerve pain subsides, the sympathetic nervous system quiets down, and the pelvic nerve can freely release NO and VIP again during arousal.
Okay, so LDN and neuromodulators can definitely fix the wiring by stopping the pain signals. But as our sources point out, there is a clear distinction between the wiring and the physical plumbing.
Right, the physical infrastructure of the capillary beds.
Yeah, because if the plumbing itself is degraded, the transudate still won't flow, no matter how perfectly the LDN shuts down the microglial cells.
That is a crucial point. The physical infrastructure of that vaginal tissue is entirely dictated by estrogen.
Estrogen is building the plumbing.
Yes. The thickness of the epithelium, the density of the submucosal microvasculature, the elasticity, it all requires consistent estrogen to maintain its structural integrity.
And the Boston University animal studies highlight this perfectly. They performed ovaryectomies on animal models to halt their natural estrogen production.
And without estrogen, the tissue undergoes profound atrophy. The epithelial layer thins out dramatically, and that dense network of capillary beds just shrinks.
So when the researchers stimulated the pelvic nerve in those estrogen-deprived models, what happened to the transudate?
It plummeted. The tissue just lacked the physical blood vessels required to sequester the blood plasma, and the thinned epithelium couldn't support the fluid transfer anyway.
There's a really interesting timeline discrepancy in those studies, though, about how that degradation actually works.
Oh, you mean the difference between Tresh and Park's findings?
Yes. Trace analyzed the models 2 weeks after the ovarectomy and found that the blood flow hadn't significantly dropped yet.
Right, but Park analyzed them at 6 weeks and recorded a massive decrease in blood flow and transudate.
Which proves that vascular decay is a progressive structural breakdown, not just an instant chemical switch.
Exactly. When estrogen drops, whether from menopause, surgery, or medications, the blood vessels don't just vanish overnight. But over weeks and months, the lack of estrogen causes those capillary beds to physically wither away.
So for the learner listening, if a patient has been dealing with long-term estrogen deprivation, applying an LDN cream to stop the nerve pain just isn't going to be enough on its own.
No, it won't be. The nitric oxide signaling might be restored, but it's sending a signal to expand capillary beds that have already shriveled up.
The hoses themselves are degraded.
Right, which severely limits the physical volume of transudate that can even be produced. The studies show that localized estrogen replacement therapy reverses this atrophy. It regenerates the microvasculature.
But the UK clinical guidelines on vulval conditions note that localized estrogen is contraindicated for certain patients, right? Like those with a history of estrogen receptor-positive breast cancers.
Yes, so for those patients, rebuilding the plumbing requires alternative mechanisms. The texts mention emerging pharmacological options like P2Y2 receptor agonists, which can artificially stimulate fluid transport.
But they also heavily feature structural interventions, like transvaginal fractional CO2 laser therapy.
Yeah, the laser therapy is fascinating. It relies on tissue regeneration through controlled injury. The laser creates these microscopic thermal traumas deep in the mucosa.
And the body registers the microtrauma and initiates a massive healing response.
Exactly. It floods the area with fibroblasts, makes new collagen, and most importantly, stimulates angiogenesis, which is the creation of new blood vessels.
It literally rebuilds the capillary beds without needing hormonal signaling.
Right, it reconstructing the plumbing.
So to put it all together for you, the learner, it's this brilliantly coordinated biological system, but every piece has to work in harmony. Estrogen or laser therapy builds the physical plumbing. Neurotransmitters like NO and VIP act as the water pressure turning the tap on.
And treatments like LDN or amitriptyline clear away the roadblocks, the microglial inflammation and chronic pain, so the sympathetic nervous system stops crimping the hose.
You can't just treat the pain if the tissue is atrophied, and estrogen won't work if the nervous system is screaming in pain and clamping down the vessels.
Everything has to be addressed.
Which brings us right back to our core mission. Does low-dose naltrexone or neuromodulators affect vaginal transudate? The answer is a definitive yes.
Yes, but through removal rather than generation. They aren't cibertagogues. They neutralize the inflammatory cytokines and silence the neuropathic alarms.
They eliminate the ultimate reflex inhibitors of sexual function, which grants the parasympathetic nervous system permission to do its job.
Exactly.
And knowing this, why completely changes the game when you're sitting in a specialist's office. You aren't just asking for a generic pain cream. You are discussing how to modulate your microglial cells or how to separate anticholinergic side effects from your localized vascular response.
It allows you to really advocate for a multidisciplinary approach. You can make sure your provider is looking at both the neurological wiring and the hormonal infrastructure.
Absolutely. Now, before we wrap up, I want to leave you with one final kind of provocative thought drawn from this pharmacology.
Yeah.
We know nitric oxide forces those capillary beds open to produce transudate, right?
Right.
Well, the Boston University data points out that sildenafil, which is a PDE5 inhibitor, better known as the active ingredient in Viagra, actively facilitates that exact NOCGMP pathway to increase vaginal transudate in animal models.
Yeah, because by inhibiting the PDE5 enzyme, sildenafil prevents the breakdown of cyclic GMP, so it forces the smooth muscles to stay relaxed and the capillaries to stay engorged for much longer.
So if compounding pharmacies are already using these mucoadhesive bases to deliver LDN straight to the vestibule to shut down the TLR4 receptors, could the future of treating complex pelvic pain and sexual dysfunction be a dual-action localized cream?
Oh, that is a tantalizing idea.
Right. Imagine a customized formulation that combines LDN to silence the microglial inflammation and remove the reflex inhibitor, alongside a localized dose of sildenafil to actively force the vasocongestion.
It would be a highly targeted pharmacological frontier. You'd be turning off the fire alarm and chemically cranking the water pressure at the exact same time.
All while bypassing the systemic bloodstream to avoid the side effects. It's the ultimate synthesis of neurology and vascular biology, applied right at the source.
It is definitely an area of compounded medicine worth watching closely.
Totally. So keep questioning those straight-line narratives, keep diving into the underlying mechanics, and keep exploring the science that shapes how our bodies actually function. Thanks for joining us on this deep dive.